then I will be happy to hand over, and I will take it from here. I mentioned that MEP Sokol will be joining us at 4 sharp. That will be virtually. So he will be from across town, but that was the best guarantee that he would be able to join us in time.
Okay, so this first session is about the new HTA regulation interface with other EU initiatives. I already introduced myself. It's a session that will be co-moderated with Mark. Mark, you can introduce yourself.
Yes, thank you, Antonella. Welcome again here at the RISIF INAMI. My name is Mark van der Kastelen, and I am the coordinator for the HTA expertise here at the Belgian National Institute for Health, and I work for the Commission for Reimbursement of Medicines. I think that will be enough, keeping an eye on the time. Yes.
Sure, and is MEP Sokol online? So I can introduce him. So MEP Sokol is very active on health. He's a member of the European Parliament since 2019, so he's at his second mandate. He has since been serving on the Committee of the Internal Market and Consumer Protection. In 2022, he also joined the Special Committee on the COVID-19, and he has been Parliament MV's rapporteur for the European Health Data Space, and is also a member of the MEPs Against Cancer Group. And I'm pretty sure I missed some other commitments, because as I said, he's very active. So MEP Sokol, the floor to you.
Thank you very much. So I think the most important thing is that I'm the member and the coordinator of the European People's Party in the Health Committee. And since last year, we've had for the first time a health committee, separate health committee in the European Parliament with full powers. So as the coordinator of the biggest political group, I have to coordinate all the legislation that is being done there. And also I'm the rapporteur for the Critical Medicines Act. So I have general responsibility relating to all the health legislation, but also my primary responsibility relates to those legislative files for which I am the rapporteur, for which I'm directly in charge. So I'll just have a short intervention, because unfortunately I will have to leave pretty soon, where I'll say what I think is the crucial thing with the HTA, but also maybe reflect a bit more also in broader terms on the innovation, what we want to achieve. So the main problem with health systems in Europe is fragmentation. So we have essentially not one health system, as you all know, but 27 national systems. And Article 168 of the Treaty on the Functioning of the European Union clearly states that healthcare is a national competence, primarily organization, financing, and management of healthcare systems. That means primarily pricing and reimbursement are the national competence. And here we have some limited rules by the EU, which set some basic principles of non-discrimination, in the sense that all producers of medicines have to be treated equally within the EU, and also EU legislation, the so-called Transparency Directive from 1989, sets some deadlines when pricing and reimbursement decisions have to be made, and that's it. The problem with this directive itself is that, as I said, it dates back to 1989, never been amended, but it's also not implemented in the right way. And I know for a fact that in many cases, member states do not make pricing and reimbursement decisions within these deadlines, 90 plus 90 days. But unfortunately, on the other hand, Commission is not really doing a lot about that in controlling the member states. So definitely that's one room for progress, at least how to make medicines pricing and reimbursement decisions be faster. But so the first problem that we have is this fragmentation, 27 national systems, and the fact that we had a lot of administering here, a lot of different administrative steps, which leads to the fact that medicines get to patients across the EU, unfortunately, at different times. So one of the reasons is administration. The other reason is that, unfortunately, smaller markets or smaller member states are not that interesting in many cases for the industry as the biggest markets. And when we take all of this together, we have a situation that innovative medicines get to certain small countries in the Eastern Europe 2 or 3 years later than to the biggest countries in the Western Europe. So this is the problem that we have to tackle with the very limited powers that we have on European level. So what we can do? So what do we do? So first we have the joint the common system of approval of innovative medicines, which is conducted by the EMA, European Medicines Agency, and the European Commission. And then until recently, that was essentially it. So we have so essentially every medicine that before it gets to the patients has to undergo 2 steps. So one step is approval on the European level if it falls within the competence and the powers of the European Medicines Agency, of the centralized authorization procedure. And then the second step is national pricing and reimbursement decisions. So now the question is, where does HTA come into all of this? And I think here, when we speak about the HTA, the final result, the end result, is not as ambitious or as efficient, as good as it could have been. And the main reason for that are the member states. I remember, because this was negotiated in the previous mandate. I've been in the European Parliament since 2019. In the original proposal, the idea of joint clinical assessments being mandatory and being equally applicable in all the member states. However, opposition of some big member states led to the fact that this legislation is now very much diluted. So it's diluted in a way that member states only have to take into account joint clinical assessments, but it's not obligatory. Also, joint clinical assessments essentially do not contain, or in most cases, or generally in principle, do not contain economic analysis, cost effectiveness analysis, etc., which is the basis for making national pricing and reimbursement decisions, which means essentially that we'll still have to retain the 27 national procedures for deciding what will be reimbursed under the health insurance or national health services. So instead of having one joint clinical assessment and one health technology assessment that would substitute for 27 national ones, now we got the European on top. And in addition to that, we still have to have national pricing and reimbursement decisions, procedures, which will make cost effectiveness analysis, etc., where this big fragmentation exists. So to sum up, EU legislation is still very fragmented. It's still very complicated, and definitely HTA, unfortunately, is not as strong as it could have been originally. Of course, we'll see now. The application has started. We'll see whether joint clinical assessments will lead in practice to more harmonization of criteria and the way how health technology assessment is carried out. This part, I hope, that will lead to some convergence and some harmonization, but this remains to be seen. On the topic that was reflected on me to speak about how all of this plays into the general health initiatives and legislative initiatives on the European level. So the main objective of the whole thing is to stimulate innovation on one side, and on the other side to make it possible for medicines to access patients faster than it is now. And that all patients in Europe have access to medicines at approximately the same time, that you don't have such discrepancies that exist today. So what are we doing? So we've had the pharmaceutical package. The negotiations went on for a very long time, and I will say the main game changer which made it possible to come to an agreement on the general pharmaceutical legislation was the Trump administration. Because when Trump administration came into power and made this enormous pressure on the industry to reinvest and redirect the majority of their investments to the US. This showed us that, unfortunately, if we don't want to lag behind and become dependent on import of innovative medicines from the US, then we have to act in a much different way than it was perceived previously. So in that sense, so this is why a compromise on the regulatory data protection was made, and also on the market exclusivity and all that, so that we at least do not decrease our competitiveness and attractiveness of our market for the pharma industry when compared to the US. So in that sense, pharma package is now a compromise. It's not ideal, but at least the stimulation for innovation in Europe has not decreased when compared to what we had before. On the question of access, pharma package unfortunately does not really deliver that much of a change. It strengthens the border exemption, which makes it easier for generic medicines to come to the market right away when the protection expires, and definitely that's one good development. So that's about pharma package. So in that sense, let's say that it retains the status quo. On the question, the second question is the Critical Medicines Act, and that's what we are negotiating now with the Council. So here I would say we have two very important things related to access to medicines and access to medicine and stimulation of innovation in Europe. So first is the public procurement. So public procurement and criteria for public procurement, where unfortunately the lowest price has been the main criterion for a very long time. And by doing this, we allowed to become dependent to a large extent on imports of generic medicines from India, China, etc. To change that, now we are introducing, and that's the position of the Parliament, to introduce a very strong European preference in public tendering for medicines. Our proposal is that those companies who produce at least 50% of their portfolio in Europe, meaning EAA, European Economic Area, and Switzerland, that these companies will have preference in tendering for medicines on the European level. And we think that this is extremely important if we want to stimulate and strengthen innovation within the European Union. Of course, not everybody agrees with that. There are some things that need to be sorted out, maybe in more technical terms about what is the best way how to define this European preference. But we believe in the European Parliament that we need to have strong, clear, measurable criteria on what is significant production in Europe, so that these companies have preference in public tendering. And by doing this, we are creating a stimulation and we incentivize the industry to produce in the territory of the European Union. The second point, which I think is also important, is joint procurement. Because as I said, we have enormous differences when medicines come to different national markets in the EU. One part is the fact that we have different national pricing and reimbursement procedures, different national health technology assessment procedures, but also, as I also said, the fact is that small markets are not that interesting for the industry as the biggest ones. So to change that, to aggregate the demand and strengthen the position of smaller member states, we are going and we are introducing in the Critical Medicines Act the joint procurement, and this joint procurement with a minimum of 5 member states. So 5 member states can initiate joint procurement of a certain medicine, and then the Commission on their behalf has to carry this out. So we believe by doing that we'll be able to aggregate demand, that will be able to strengthen the negotiating position of the member states, and by doing that, we'll be able to get the medicines faster at more reasonable prices, especially innovative medicines, to the patients across the EU. Of course, I believe that here in the area of joint procurement, joint clinical assessments will play a major role, because definitely if member states are trying to come together and aggregate demand, I'm certain that joint clinical assessments of medicines will be taken into account when defining what the priorities for this joint procurement will be. Of course, it's not realistic that this joint procurement will cover hundreds of medicines, because it's a lot of administrative work, and it's not realistic to imagine that will be able to pull several member states to work together on many medicines, but on the most important medicines with the clearest, biggest added value and clinical benefit, definitely the joint procurement that in these cases makes sense. And I think joint clinical assessment assessments here will play a major role when member states decide what their compromises for this joint procurement should be. So in that sense, to sum up, when you speak about accessing patients being given access to medicines across the EU, we have a lot of problems, very, very complex regulatory framework. After the approval on the European level, medicines have to undergo 27 national pricing and reimbursement and health technology assessment procedures, which definitely results in many delays for patients accessing the most innovative medicines. In that sense, HTA regulation can help. Joint clinical assessments can play a role. It could have been stronger. Legal wording and legal obligations could have been stronger. But I think that if we are able to pull through this joint procurement on the European level, that joint clinical assessments in that sense will play a major role when member states decide what their priorities for joint procurement will be, and in that sense, definitely, I think the HTA regulation will play some role, and what role that will be, of course, remains to be seen. So I think I covered everything that I wanted to say. Thank you for inviting me. And if you have any questions or suggestions, please feel free to ask. And I apologize for the lightning. Here we have these great green rules that the light goes on off automatically if you don't move. So this is why this happens. So I apologize for that, but that's outside of my control.
Okay, so thank you, MEP Sokol. As you are leaving, I think we can go for some get some questions from the floor. While the audience warms up, I comment what you just said, and I think that we share the same concerns about the JCA and the challenges of the JCA and the implementation of the HTA and the price reimbursement at the member state level, which remains extremely fragmented. So I think that, so with this, I see that there is a question. Yes.
Okay, so my name is Natalia Harszkiewicz-Birkemeyer. I'm a scientific policy expert for the European Commission. On the LinkedIn website, we can also follow very active schedule of DG Sant, so the Public Health Committee of the European Parliament. And there are also several initiatives already ongoing, for example, related to the Europe's Beating Cancer Plan. There is also the report related to the rare disease plan, as well as one report related to patients' centricity. Could you elaborate very briefly on these three initiatives and their link with the HTA regulation? Thank you.
Yeah, I mean, there is no direct link with HTA regulation, to be perfectly open. I mean, so just maybe to clarify some things. So these reports that you're mentioning are so-called own initiative reports. So this is not legislation. These are reports that Parliament makes on its own initiative to state its position on a certain topic. And the topics that you mentioned one is Europe's Beating Cancer Plan, that's now been several years in the implementation, and the other is on rare diseases. I don't understand what the third one is.
The third one is related to patient centricity. It's pretty a new one, I would say.
Patient centricity. We don't have such a title. Maybe if you can, maybe do you have a concrete title on what you're actually referring to?
Just a moment. Yeah, it's titled Patient-Centered Health Research and Innovation in Europe.
So it's about research.
One week ago, approximately.
No, okay. So it's about research innovation, because everything that we do, we try to make it patient-centered, but that's not the distinction, because we try to do it in everything. So about research innovation, yeah. Okay. So as said, on initiative reports where we state our position on certain topics. So we have been we have the implementation of Europe's Beating Cancer Plan. That's been several years already in the making, and of course now we have to let's say determine where we are and what needs to be done. So whether this report will make a reference, and in what way the final report will make reference to the HTA, of course, remains to be seen, because we are just now we actually haven't started negotiations. We just are in the process of drafting amendments. But probably I assume that also HTA regulation should come up in the final version. The thing is that Europe's Beating Cancer Plan is the weakest part of Europe's Beating Cancer Plan is on treatment. And to be honest, 95% of all discussions on Beating Cancer Plan unfortunately, is about alcohol and tobacco, and what to do with alcohol and tobacco. So the treatment itself is not that much discussed. But definitely we want to change that. We want to have more references to how to improve treatment across Europe, how to better coordinate, how to use European reference networks more, and definitely how to get medicines to patients faster. And I think definitely and hope that the final report will have references to Europe's Beating Cancer Plan, to the references to HTA regulation in some form. On rare diseases, we are already in the process of negotiations. For me, rare diseases are the most important, I say, area where EU can provide the biggest added value, because rare diseases are one area which member states cannot resolve by themselves. So the gaps in access to medicines is enormous. 95% of patients who are suffering from rare diseases do not have access to medicines. So I assume, and I know that also health technology assessment and joint clinical assessments have to be mentioned there as something that can make harmonization of standards easier, and in the end, hopefully, make it possible for patients to access medicines faster. When I speak about orphan drugs, what is important is that we want to include all of them in the Critical Medicines Act. That's one of the main points of contention, because some member states don't want that. So we want all orphan drugs to be included in the Critical Medicines Act, so that they can all benefit from joint procurement. Because joint procurement by member states is an area which can provide the biggest added value for orphan drugs. Because in many cases when you have 2 or 3 patients in small member states suffering from rare disease, obviously in cases like that, it's very hard to access orphan drugs, which are then very expensive and not financially feasible in many cases for national health insurances. But if you pull 6 or 7 smaller member states together, if you aggregate their demand for orphan drugs, then it can definitely become much more financially viable for them to purchase these medicines. They can reduce prices and make access to these medicines easier. So I think that joint procurement will provide the biggest added value for orphan drugs in relation to orphan drugs, and because of that, we want to include all the orphan drugs in the Critical Medicines Act to make it possible that they are bought in this accessed in this joint procurement. So I think from that point of view, health technology assessment for orphan drugs, for critical medicines could play a major role, as I already mentioned in the introduction. And this is also something that will not just in the Critical Medicines Act, but that will be reflected in this own initiative report on orphan drugs, on rare diseases as well, where orphan drugs will play a major role. And on the rest that we are working on related to innovation, this is also something that is extremely connected with health technology assessment, with all the problems that I already mentioned. So definitely our future reports, all initiative reports related to innovation, will also related to the Biotech Act that now we are starting our work on, definitely will also mention the HTA regulations. So as a reflection on why HTA is important, etc., etc. Legally, these new things that we are doing will not change HTA regulations. HTA regulation is as it is, so it will not directly influence. It will not change HTA regulation. It will not directly influence it, but of course, it will make a reference to it, and by making references to HTA regulation, it will make this joint process on the European level gain more visibility. So in that sense, it will be reflected, it will be mentioned, but it will not essentially change anything in relation to actual implementation of the HTA itself.
Thank you. We have one last
Thank you very
question.
much.
Thanks very much, MEP Sokol, for this great overview and insight. So I'm Jörg from the European Access Academy. One of the topics we will focus on during those 2 days is to look into the 27-28 revision of the regulation. And there are a couple of ideas in the room. For example, the instrument joint scientific consultation is not really developed to the extent it should be. Companies are currently entering the JCA process without being informed in advance about, let's say, the PICO scheme. They should develop the comparator, they should be developed. So from our point of view, this puts Europe in a competitive disadvantage because let's say JCA should proceed, JSC should precede the JCA approach. Those are elements we would be looking into. Also the opportunity to enhance the use of evidence-based medicine into the medical societies, having a consolidated perspective from medical societies, from patient societies, beyond individual capacities to, let's say, comment on the process and avoid this one becoming a bureaucratic process in an ivory tower environment and really embedded in a social, broad, stakeholder-driven and societal discussion. Could you share perhaps a couple of your ideas from your perspective where you are looking into in terms of the revision of the regulation 27-28? What are your current considerations? What do you want to change there? Thanks.
Okay, the first thing that I already mentioned in the introduction, we need to clarify what its legal role is. So where does it fit and what is its main purpose? And I think from the text of the regulation itself is not that clear, and also the relationship with the member states, because to only say that that this is something that needs to be taken into consideration or into account or whatever is not enough. So we need to have a clear mandate that this is mandatory, that this needs to be accepted by the member states, and also to clarify what its relationship with then national pricing and reimbursement decisions will be. So to actually define what the role of the HTA within this whole ecosystem is. I think that's not clear from the text of legislation itself. I don't know if they will be able to do it, if it will be successful, but I think that's the main point. On the things that you mentioned, I think I essentially agree with all of them. I know that we fought very strongly in every legislation. We fought very strongly, still fight to include stakeholders as much as possible, to include the health experts, the industry, the patient groups in the governance framework on the European level. For us, this is very important. I've been doing that also in the context of the European Health Data Space, in the context of Critical Medicines Act. So this is something that I will definitely support, and everything that will increase and that will increase our competitiveness, that's something that EPP will support. So maybe we can engage in more detail when the time comes on this. We are open to concrete proposals on what needs to be changed to make things easier and faster. But I think definitely when I speak about stakeholder engagement, I fully support that. On the question of better legal definition of the role of the HTA is essential. On the question of evidence-based medicine and how to and use of data, I think European Health Data Space can and will hopefully play a major role there. I was the rapporteur for the EHDS. Here it will be essential that we prepare the application and implementation of EHDS very strongly, because different parts of EHDS will start to be implemented at different times in the next 4 to 5 years. So we have some time, but the crucial thing will be to prepare the system, to build infrastructure where this infrastructure is lacking, and definitely European investments will be needed there as well. And I think that if we're able to do this right, to build this system of use of data, then definitely it will be easier to make evidence-based decisions. And in the context of the HTA, that's also something that is extremely important. One thing that I forgot to mention also is the question of the health budget, because on the European level, because European financial support is necessary for a lot of these things that we are mentioning now, including obviously the joint clinical assessments. Here, the problem is that the Commission in the new proposal for the next 7-year budget does not have a separate health budget at all. So they're essentially killing you for health and putting health on the competitiveness fund, but without earmarked ring-fence funding. Parliament is against that. We lobbied very strongly within the Parliament, and now yesterday it was voted in the budgetary committee of the Parliament that the Parliament's position will be that we need to have separate ring-fence funding for health in the next 7-year budget of the EU in amount of at least 10 billion euros. So on one side we have Commission, no separate health budget, and the Parliament to ask for at least 10 billion euros. And here also the implementation of the HTA regulation should play a major role. It will be a major fight because the Commission, as I said, wants to kill the EU for Health program. We don't know what will be the situation with the Council, with the Member States, but I hope that in the negotiations we'll be able to retain and to protect the European health budget, and then we'll have funding for a lot of these things that we are mentioning today as well. Also, if you can put pressure on the national governments in your context, in your countries, to be open to retaining a separate EU health fund in the next 7-year budget, that will be very helpful.
Thank you.